We are going to start module 2 with chapter 14, mental health disorders. And there's a lot of information in the text. And I'm going to divide it into 4 shorter lectures. We're going to start just with a little intro and mood disorders. We're going to talk about anxiety disorders, cognitive and other sorts of disorders. And I'm going to have one section just on dementia, even though that is a cognitive disorder. There is a section in the book on substance abuse disorders, and I'm not going to have any lectures on that. We're not going to spend a ton of time on it. But it's good information if you want to read through it in the book. And if you're interested in more in-depth, that is something you get continuing education on. So our learning objectives are to be able to discuss risk factors, etiological factors, pathogenesis when it's appropriate, and clinical manifestations for a variety of different mental health conditions. We're also going to talk about how this affects physical therapy, what happens in the physical therapy world. So mental disorders are classified in a reference that's called the Diagnostic Statistical Manual of Mental Disorders, or the DSM. It's currently in the 5th edition, and it's interesting when they come out with new editions. Some things that used to be considered mental disorders that now are not are taken out in a new edition. And it's not very often that they publish a new edition. I think that it's been at least 10 years for DSM-5. But also things that weren't previously categorized as mental health disorders show up in the new edition. So some of the newer things that came out in DSM-5 is they have different things like anxiety as a result of certain things, like anxiety as a result of stimulant usage, and other things. So it's evolving. What we consider to be a mental health disorder is always evolving. And obviously, we do not treat mental health disorders in physical therapy, but as I always say, nobody leaves their mental health disorders at home when they come in for their PT appointment. So we need to know about it. So the mental disorders are generally considered dysfunctions in the areas of behavior or personality. They can be biochemical or structural. Lots of the things that we think of as mental health disorders, like depression, anxiety, etc., are biochemical. So there's a big stigma that goes with mental health disorders, but why should there be a stigma for biochemical disorders? Interesting, right? And then also structural abnormalities. So something is structurally different in the brain that is causing this problem. There might be a genetic component that leads to particular things. Certainly, if one or both of your parents were prone to depression, let's just say, then you might be prone to depression as well, because you might have the same biochemistry as your parents since you got your genes from them. There are psychotic illnesses, including schizophrenia, delusional disorders, mood disorders, and anxiety and panic disorders. And those are generally biochemical, and they generally are treated with medications, as well as other types of therapy. So we'll talk about it. So why does this matter for PTA? So mental health conditions can significantly impact rehabilitation outcomes. Like I said, nobody leaves their mental health conditions at home when they come into PT. So a lot of people who come in for various things, orthopedic, neurological, whatever they're coming to PT for, they also have mental health conditions. The cognitive changes that happen with mental health conditions can affect treatment planning and patient safety, as well as the medications that people might be on can affect patient safety. Communication strategies might need to be adapted for certain things, and we'll talk about different communication strategies for certain disorders. And recognition of symptoms as being part of the mental health condition helps with appropriate referrals. And it helps you understand your patient better and maybe what might motivate them. So we should always consider both physical and mental health factors when working with patients. So when we looked at that international classification of function and disability, there were lots of different factors that went into function, right? And mental health is certainly one of those things. So, some of the mental health conditions that we'll talk about can mimic or complicate other medical conditions. And this is a big thing to remember. As a PTA, you're not diagnosing mental health conditions. PTs aren't diagnosing mental health conditions, but understanding them helps us to provide better patient care and recognize when to communicate concerns either to the supervising PT or to the physician or to the appropriate member of the healthcare team. So it's very important that we know about these, even though we're never diagnosing or really directly treating them. So in PT practice, of course, we see lots of things that are a result of mental health conditions. Patients with depression might not be motivated to do their exercises, and that's understandable. I was reading, there's a really good book that's called Do One Thing Different, and it's written by a psychotherapist named William O'Hanlon. And he was talking about a particular case study where a patient with depression just couldn't do anything. You know, they were like that far down that they couldn't do anything. And his plan for doing one thing different, the patient decided the one thing they were going to do is walk to the mailbox. Just that's it. And just walk out to the mailbox and walk back. That was the one thing they were going to do different. So they did that for a couple weeks, just walked to the mailbox. And then one day they walked out there and they said, well, maybe I'll just walk up to the end of the block. And then they progressed and eventually kind of got out of it because the exercise certainly helped. But that, you know, so that motivation is it might not be there. Anxiety can affect pain perception and treatment compliance as well. So if somebody says, "Oh gosh, the anxiety is causing an increase in pain, and I'm in too much pain to do my exercises," that could be a problem. PTSD may cause patients to avoid certain movements or positions because it might trigger their PTSD. I have had some interesting PTSD encounters in the clinic, which I'll tell you about when we talk about that. Eating disorders can complicate recovery from injuries because they can affect muscle recovery and cardiac issues if electrolytes are out of balance. So eating disorders can throw a big monkey wrench in the whole thing. So medication side effects, if someone is on medication, especially antipsychotic medications, they can affect balance or cognition. So a lot of different medications can affect balance or cognition. A lot of mental health disorders require modified communication approaches. That is really important. And it's important for not just for people with mental health conditions, but for everybody to create a safe, supportive environment. But it's especially important for people with mental health conditions. We need to collaborate with mental health professionals. We need to know when to refer appropriately and what the person is dealing with. Mental and physical health are connected, and addressing both leads to better outcomes. So I've had people with spinal cord injuries that needed mental health support. Understandable. That's a life-changing, devastating injury. And so addressing both really is going to have just better outcomes for the patient, and that's what we want. So the types of disorders that we're going to talk about, in addition to dementia, which is a cognitive disorder, but we're going to especially focus on that. We're going to talk about mood disorders, anxiety disorders, schizophrenia, cognitive disorders, eating disorders, and somatoform or factitious disorders. So we'll go through all those. So mood disorders are common. They're disturbances and emotions that can cause subjective discomfort and or impair a person's ability to function. And that's a distinction that I often make. All of us experience sadness at some times. That's not depression necessarily. All of us experience some level of anxiety at times, and that doesn't mean you have generalized anxiety disorder. But when does it cross over into a disorder? And what I always say is if it impairs your ability to function, that's when it goes from just, okay, this is going on, to a disorder. So, mood disorders tend to run in families. There is a biogenic cause. Usually, it has to do with production of neurotransmitters, norepinephrine and serotonin, particularly. You either have too much activity at the synapses, and that results in what they call mania. We'll talk about that. Or too little activity, and that results in depression. So, the types of mood disorders that we're going to talk about are depression and bipolar disorders. So there lots of factors go into creating these conditions, including genetic, developmental, and psychosocial stressors. So depression, we'll talk about the affective presentation, like how do they appear, and the cognitive presentation, how are they thinking, basically. So the affective presentation with depression is sadness, dejection, prolonged mourning, maybe feelings of worthlessness, loss of the joy of living, which is called anhedonia. The cognitive presentation is pessimism, disinterest, decreased energy, loss of motivation, self-denigration, and low speech volume. I think we can all picture this. Maybe we have experienced it, or we know someone else who's experienced it. There are special forms of depression that are associated with different things. Persistent depressive disorder is also known as dysthymia, and it's a depressed mood that lasts at least 2 years with varying severity, which, that's a long time. But, postpartum depression, it's a major depression either during pregnancy or after delivery. It's more serious than just the baby blues, people will say. And it can be seriously debilitating for people. So now you've got this new baby and you have postpartum depression. That's not a good combo. Psychotic depression is severe depression plus psychosis, and psychosis includes delusions, hallucinations with depressive themes, that sort of thing. So definitely that one probably needs to be treated with medication. And seasonal affective disorder is depression during the winter months, and it lifts during spring and summer. It has a lot to do with light exposure. So I don't know if you know this, but in the counseling office at Whatcom, you can check out a happy light for the winter if seasonal affective disorder is affecting you. When I first moved to Washington, I had a huge problem with seasonal affective disorder. And I didn't really know anything about seasonal affective disorder, and I just thought I hated it here. But then come the spring, I felt better. Like, that's interesting. And then when the next winter rolled around, I felt worse. And then I started reading about seasonal affective disorder, and I did get a happy light. The other thing I did is I made sure that I had interesting, fun, engaging activities to do during the winter months. So that really helped me a lot. But the happy light, if you need a happy light, check one out from the counseling office. So there are a lot of different treatment options for special forms of depression. Antidepressant medications, selective serotonin reuptake inhibitors are the most common. So those are things like Zoloft and Prozac and those sort of things. I always say that walking outdoors is nature's Prozac. It's just me. Psychotherapy can be helpful. Talk therapy or cognitive behavioral therapy can be very effective for treating all forms of depression and lots of other things. Brain stimulation, electroconvulsive therapy, transcranial magnetic stimulation. That's a relatively new treatment that has been shown to be effective with a lot of different mental conditions. So for our patients in the clinic, if our patient's depressed, it can significantly affect their motivation and decrease their energy levels. So patients might just have difficulty doing their home exercise program. It might be just overwhelming for them. Sometimes just giving them a breathing exercise to start with might be a good thing because that's doable. You could do it lying down. But exercise is proven to help with depression. That's my walking outside is nature's Prozac thing. Emphasize this benefit, but be aware of suicide risk and know your facility's protocols. The National Suicide Hotline, 988. Anybody can call that at any time to get help. So let your patients know that's available. If somebody says they're having suicidal ideation, ask them if they have a plan in place. That is something to know about. That is something to notify the supervising PT and the patient's physician about. Don't keep it a secret. We got to help these people. Bipolar disorder is interesting. So there are three different types if you want to think about it. So bipolar is classic bipolar. They used to call it manic depression. It was sort of cycling between manic, which is like way elevated mood, and depression, which is way depressed mood. So now they say bipolar 1, which is basically you go from average to manic and then back to average. And bipolar 2 is you go average to depressed and back to average. And cyclothymia is you cycle between depression and mania. So the effective presentation for bipolar 1, which is the mania side, is elation or irritability, grandiosity, decreased sleep. The sleep should be over there under the decreased. Impulsivity, exaggeration, boundless energy or the appearance of boundless energy, verbally and sexually uninhibited. Cognitively, you'll see accelerated or pressured speech, tangential content, so moving from one subject to another really quickly, and disjointed thoughts and speech. Bipolar 2, the symptoms are very similar to depression, except for people cycle in and out of depression. And cyclothymia is you're depressed and then you're manic and then you're depressed again. So it's an interesting, and it's biochemical. It used to be known as manic depressive disorder, and it's those alternating periods, extreme activity and euphoria, or periods of depression. So highs and lows, basically. The depressive episodes, similar to clinical depression, the manic episodes, extreme confidence and productivity, poor decision making. People tend to overspend, like they buy a bunch of stuff during their manic phase and then they sell it all during the depressive episodes. Manic episodes can lead to overexertion and poor judgment about person's physical limitations. So it's very difficult for people to deal with that particular thing. So that whole like, oh, I'm gonna go like, oh, I'm gonna make sourdough, and you go out and buy all the accessories, and then when you're depressed, you're not even doing your sourdough just dies. And I'm just using that as an example. I'm sure there are lots of other examples. So there is a strong family history component. So there's a genetic component. Brain chemistry is neurotransmitter imbalances. Certain drugs can trigger manic episodes. And one of my friends who's an ER nurse said that when people come in to the emergency room in a manic stage, the first thing they do is give them anti-mania drugs to get them down off that mania. It can be associated with anxiety disorders, ADHD, substance abuse. It's treated with medications. Lithium is a mood stabilizer, and that's usually overall medication. Antidepressants, selective serotonin reuptake inhibitors, anti-anxiety medications, and antipsychotics. Other interventions include psychotherapy, electroconvulsive therapy, and transcranial magnetic stimulation, just like for depression. A lot of patients dislike the flat feeling from medications. And so they don't want to take the medications. So be aware of potential medication changes affecting treatment. I worked with one patient who had bipolar disorder and didn't like to take his medications because he liked the feeling of the mania. So he told me, and you could tell when he was in the manic phase. He'd come into the at the time the clinic I worked in, we had a phone in the lobby that the patients could use. It was pre-cell phone days. And so if they needed to call their ride or whatever after their therapy treatment, and he'd come and check in at the front desk. He'd yell at the front desk people, and then he'd get on the phone and call somebody up and yell at them. I don't know who he was calling, but he was just, you know, that over the top. And he was quite loud in the gym, quite difficult to deal with. It was hard to calm him down and get him to focus on doing things. So finally, what I ended up doing with him is I made him a contract. In order for him to continue with PT, he had to do this and this, and check in. And he actually did. He had back surgery. That's why he was in PT, and he actually did get better. But it was a challenge. It was a real challenge. So if you see significant changes in your cognitive status, talk to the supervising PT. New concerning behaviors or statements, like if people have suicidal ideation or other statements they might tell you. If there are safety concerns, either for that patient or other patients or you, um, if the patient's expressing suicidal thoughts or if they are unable to participate in therapy for any one of those any reason, that's when you want to go to the supervising PT and say, what's the deal? So with the person I was just talking about who's yelling on the phone, I did talk to the supervising PT and say, like, what are we going to do with this guy? And the interesting thing about him is he didn't want to see the primary PT. He just wanted to be on my schedule, which, as you know, you can only be on a PTA schedule um, for 5 visits, and then you have to see the PT to check in. So he would always cancel that appointment, and then it would cause problems. So the contract kind of uh, took that into account, but very challenging patient to work with. So for PTAs, mental health conditions significantly impact physical therapy outcomes. We need to adapt our communications and treatment approaches based on the patient's condition. And safety is very important. So assessing cognitive capacity and fall risk. If somebody is underestimating their physical limitations because they're in a manic phase, that could decrease their safety. Exercise and physical activity can benefit their mental health. So if we can get them on a regular program, that's great. Not always easy, but we can try it. You should know when to communicate your concerns to the PT and maintain professional boundaries while providing compassionate care. And that goes for every patient, but particularly with mental health patients, because it is easy to get frustrated with them and get snippy because they're driving you crazy or whatever, but you have to keep your cloak of professionalism in place.